Chap. So, Rudrajit, start now.
Yeah, so before start, just one notice. We are going to do the case presentation on Monday. So we will tell you, give you a list of the people who are there for the next 4 or 5 weeks, and we'll go accordingly. And if there is anyone who is doing a problem or a duty on that day, you'll have to let us know, and we are going to put another person in place of your case. So please start with your sir.
Yeah, just let us know from before if somebody has a duty so that we can change it around. Okay, so that's part of the thing. Right. So we're going to discuss. We have already discussed benign SOLs of the liver, and now we go into malignant. And then the malignant, obviously, the more common is spread to the liver, secondary involvement, metastases. But before we do that, we need to always remind you, no matter what you're doing, no matter which subject you're discussing, there's a ladder that you have to correct. And I'll make it very obvious why it is that you need to start with history and do a thorough history, a thorough clinical examination, because without these two, you can't go to the next stage of confirming the diagnosis with appropriate test or, for that matter, instituting appropriate treatment. So it gets completely destroyed if you don't follow that step ladder. And because of this, I'm going to give you a bit of a background and something which is perhaps a bit not so surgical. And this was one of the famous painters called Peter Paul Rubens. And do you know the story behind this? Anybody? He called this Prometheus Bound. And for people who have read Bloomgart's excellent um, 2 volumes on um, liver surgery, you'd come across this as the frontispiece. So this is Peter Paul's Rubens. This was Prometheus. Prometheus was a god, and he had a very strict father. The father was Zeus. And what Prometheus did was to give humans the knowledge of fire, which was actually something that only gods before that knew. And so humans started building fire, and this was mythology, Greek mythology, and they started, you know, comparing themselves with gods because, you know, they had access to fire. So as a result of which, Zeus ordered that his son Prometheus be bound in chains to the top of a mountain. And every day a bird of prey, that one, came and ate up his liver for it to regenerate. And the thing happened all over once again. So this was perhaps the first known knowledge of the regenerative capacity of the liver. You know, that liver was eaten up by this bird of prey and it regenerated. So as a token of respect to the regenerative power of the liver, this picture
Actually, there is some problem in Dr. Sanjay connection. So please wait for some time. There are some problems of Dr. Sanjay connection. Please wait for some time.
Sorry about that, chaps. I think I need to start sharing my screen once again. Rudrijit, is my screen visible? Hello.
Yes, sir. So,
Okay, thank you. Sorry about that, chaps. All my connections are playing up today. I don't know why. So coming back to Sir James, you see the year 1851, and he died in 1926. Way back, Sir James at the Aberdeen and the Charing Cross Hospital was the first to realize that the liver had two lobes. And he said it's theoretically possible to tie the vessels at the one side of the gate of the liver, supplying an abnormal growth in one or the other of the liver lobes, leaving the other side to do the work. So that's Sir James for you. But equally important is this man called Claude Quinault. He was a French surgeon, 1922, and he died in May 2008. He's a French surgeon, an outstanding anatomist who's best known for his detailed anatomic studies of the liver. And he was the first to describe its segmental anatomy. And these anatomic facts permitted the development of later hepatectomies. And what were they? This was what he described. What he described was that he described that the portal vein and the hepatic artery actually broke up into various, broke the liver up into various segments. So you had a segment 2 starting from the left. You had together a segment 4 and 3. And in between 4 and 3 and 2 was the left scissura. And 5 and 8 was divided from the right part, the segment 6 and 7 by the right scissura. And in between the scissura, what was there was actually the hepatic veins. The hepatic veins were there. The right scissura carried the right hepatic vein, the left scissura, the left hepatic vein, and the main scissura, the middle hepatic vein. And we had the gallbladder in between. So effectively, the gallbladder was the site, and the middle hepatic vein out here was the site that divided the liver into a anatomic left in an anatomic right lobe. We also had the caudate lobe, which was separate, and that was called segment 1. So this is all right for a diagram, for a schematic diagram. This is what it looked like in the human body. So you had a segment 2, you had a segment 3, you had a segment 4, you had a segment 5 and 8, and there was the middle scissura out here and the right scissura out here, and a segment 6 and 7 on this side. So what you notice, because 3 and 4 were together, and this is important, can anybody say what this is? The hilum of the liver. You have the portal vein, you have the hepatic artery and the bile duct out here. So what is this segment? Anybody? What do you think is this ligament leading in?
Umbilical ligament, sir.
So what is that?
Falciform.
Falciform. Good. So
Well,
that is the falciform. Absolutely right. But see what happens out here. The moment you go trace the falciform in, because 3 and 4 were together, see what happens. The artery and then goes into 4. So does the vein. The vein also, the portal vein also ditto. It goes out, it curves in out here. So if you were doing a left lateral segmentectomy, you had to be very careful. If you weren't careful at the site of the falciform ligament, you know what? You will end up taking off the blood supply to segment 4. But all of segment 4? No, not quite. Let me show you a bit more of a thing, making it slightly more difficult. So that is the segment as it lies in the body. And these are the planes. So you had, this is called the Cantley's line, Sir James line. That was the middle, segment. Everything on the left was a left lobe. Everything on the right was a right lobe. But you also had two other segments. You had the right scissura, which separated 4 and 8 from 6 and 7. But see what happens out here. The moment you had one segment out here which separated 3 and 4 from segment 2. If you look at that diagram, that is what it was. But the moment you drew the transverse scissura, see what happens. The transverse scissura divided the liver into 8 on top, 7 on top, and 6 out here, 8 on top, and 5 out here. Segment 4 was unique in that it also straddled the top and the bottom, but 3 was actually inferior to the transverse scissura, and 2 was on the left of it. So now see what happens. If I draw a line, you see that is why segment 3 shares a common blood supply with which part? Not all of segment 4, segment 4B. You realize that. So it shares it 4B. Whereas if you go up to segment 4A, that is behind. It's actually common to this segment as well. Okay. That's mine. So now, if I were to actually show you the correct position of my segments, see what happens. So that is the portal vein and the hepatic artery. And the drainage was up into the hepatic veins, the middle hepatic, the right hepatic, and the left hepatic. But truly, if we were to divide it, this is what it should be. So you see, 3 lies below the transverse scissura. So do you recognize that now this has a common blood supply, whereas the segment 4A would share a common blood supply with segment 2. So if we go back there, you see that segment 4B shares a common blood supply with segment 3. Segment 4A shares a common blood supply with segment 2. The reason is 3 actually lies below the transverse scissura. So just recognize that entity. So there we are. So if we now draw it once again, okay, so that's the transverse scissura. So you need to understand, and we'll go through this once again when we are doing primary hepatomas HCC. Right, now that is what the superior view is. When you're looking at on an imaging, it is 2, 3, 4A, 8, and 7. Inferior view, you see 2, 3, but you see 4B, you see 5, and 6. So now you can recognize why this is the change. And remember, 3 shares a common blood supply with 4B, whereas 3, this is not too much of a big segment. 2 shares it with 4A. Right, an understanding of the segmental blood supply of the liver and innovations in various energy sources revolutionized liver surgery. And we'll go through it next class when we go through HCC of all the energy sources and how hepatectomy is carried out. But if you look at liver tumors, you have primary liver tumors, which we are going to address at the next Thursday class. You have secondary liver tumors, of which you had 2 types of secondary. You had a direct spread and a remote spread. Both happen equally promptly. So as I said, you have to go up the ladder. So we have a 56-year-old housewife who presented with yellowish discoloration of the sclera and urine for the past 4 weeks. She has had intense itching for the last 3 weeks and has noticed that her stool color is gradually becoming more and more pale. She's not febrile. She has recently developed a mild pain in the right upper abdomen over 2 weeks, together with nausea and occasional vomiting. Now, I want you to remember, because you know what? One of your faculty members was commending the way that you people respond and can get through a CT scan. And he was very impressed. And I was very proud. But you know what? Today, you will have to refer back to this clinical scenario. If you don't remember the history, it is going to be difficult for you to diagnose that CT scan. And I'm gradually taking you through more and more difficult CT scans. So I think I'm very proud that you've been able to do the CT scans excellently. I think that's extremely commendable. So she's not febrile, but she has recently developed a mild pain in the upper right abdomen over 2 weeks, together with nausea and occasional vomiting. Her family says that she appears to have lost weight. There's no significant operative or medical history. Full-term normal delivery some 30 years ago. No significant family history. So what about the modified, what will you ask for a modified Kupuswamy scale? Now I need one of you to just tell me the 3 things that Kupuswamy scale depends on, because you won't get to the CT scan unless you are completely comfortable with this. So modified Kupuswamy scale. Anyone?
The profession, education, and income of the head of the family.
Great, absolutely. So quite right. 1976, education, occupation, and total per capita family income. So that is something that you have to remember. It's not one person's income. It's the income of the whole family. And what was it? This was it. So you score them: profession degree 7, graduate 6, intermediate 5, high school 4, middle school 3, primary school 2, 1 is illiterate. Professional 10, semi-profession 6, clerical shop and farm 5, skilled workers 4, semi-skilled worker 3, unskilled worker 2, unemployed. Now this was the problem. 1976, if you were earning 2,000 per capita family income, if you're earning 2,000 above, you scored a 12. Who earns, I mean, we were, because when we became and we had a rich salary, and we were very ecstatic at, because today we were going to earn a huge amount, a king's ransom. And what were we going to earn? We were going to earn 300 rupees a month. So you can well imagine. So that needed changing. So what changed was everything else stayed the same. The total per capita family income per month had to change, and that was the modified Kupuswamy scale. And the modification depended on the All India Consumer Price Index. Now you have to, I'm sorry, but you have to know that, at least you don't need to know the values, but you need to have an approximate idea that anything around 50,000 was 12, 25 to 45 or 50 was 10, 15 to 25 was 6. No, I'm giving you a ballpark figure. 10 to 15 was 4, 7 to 10 was 3, 2 to 7 was 2, and less than 2 was, 1. Okay, so please remember that, that was the original income, and that has been revised by the All India Consumer Price Index. So remember that you have to know the Kupuswamy scale. Okay. So this is another scale, Prasad scale. If somebody asks you, remember that you just need to know that there's also a Prasad scale. Right. Now on examination, alert, conscious, cooperative, oriented with time and space. She has icterus. Now you will be asked, where do you see the icterus? And you've had plenty of classes on that. I don't expect you to miss out on that. Please do not miss out on where do you see the icterus. Clubbing, classification of clubbing, 1, 2, 3, 4. You have to know that. We did it at the last class. Slight pallor, where do you see pallor? Has shiny nails. Why does she have shiny nails? Because she has pruritus. No swelling in the left supraclavicular region. Know that it's called, you know, what is the lymph node called?
Virtuous.
Virtuous lymph node. What is it? It lies between the two heads of the sternocleidomastoid. So it's not classically a supraclavicular lymph node. Okay, remember that. Performance status, Karnofsky and ECOG, you cannot get it wrong. She has a BMI of 23. Okay, so I'm going to ask you some questions on this before we go to the CT scan, because I don't want you, I want you completely, we at CCC want you completely solid on this. Nobody at no examination would be able to hold you out here. Okay. Abdomen is firm, enlarged, liver 3 centimeters below costal cartilage, span is 15 centimeters, slightly tender with an irregular surface and continuous with a hard, oval, irregular, minimally tender lump, both moving with respiration. Okay. Remember all this. She has icterus, and you know, it is going to be important when you get to the CT scan. Couldn't feel the kidneys, spleen is not palpable, no free fluid in the abdomen, auscultation normal, digital rectal examination, you could feel a normal uterus, there's no shelf. It's called the plumber or the Blummer shelf. You know, some people spell it, you know, internet is completely divided 50-50. P in 50, B in 50. So plumber or Blummer shelf. It's also called Schnitzler's metastases. So remember that name. Okay, right. So Karnofsky scale, don't get it wrong. You know the categories. It goes down from 100 to 0, whereas ECOG goes exactly the other way. It goes up from 0 to 4. Okay, so it's easier. But then if you're going to talk of ECOG, you have to justify a diagnosis of cancer. Remember that. If you're doubtful, you have your case, you have a doubt, I'm sorry, but go in for the Karnofsky. Okay, right. Right. BMI of 23. So what do you have? Any person? Any comments on a BMI of 23? Overweight, normal, underweight?
Normal weight. You have a normal BMI, sir.
Okay, right. Now the important thing is that, remember that in India, that's the WHO criteria. Okay, it would be normal in a WHO criteria, but I think Dr. Rudrajit Sinha told you, and that is purposely why I put it at 23. See, 23 features here. Can you see where it features? It features as an overweight in India. Okay, so that's the Asian value, 23. Remember that. Okay, so this is, if you don't remember that, please take a screenshot of this. You cannot afford to get this wrong. You know, these are basics. You can't afford to get the basics wrong. And Dr. Rudrajit Sinha had an excellent talk on bariatric surgery where he spent a lot of time on this. So please remember, and that is the reason I put in a scale of 23, because according to international criteria, you know, she would have been there, normal. But according to Indian criteria or Asian criteria, she slightly just about tilts the scale at being overweight. Okay. I purposely asked for 23 so that, you know, you could actually sort of understand the difference. So remember, if you don't remember this, take a screenshot of this. Right. Right, now we've got this patient, we've got a blood, which a complete blood count is normal. Urea and electrolytes are normal. Her liver function test, bilirubin is 7.3 grams. Direct is 5.8. Alkaline phosphatase 654. Gamma GT is 1142. Minimal rise of SGOT, SGPT. Albumin is 2.8 and an INR of 1.2. First, what do you mean by direct bilirubin? I'm sorry to repeat these simple things over and over again, but I need a response from you chaps.
Conjugate bilirubin.
Why is it called direct?
Sir, directly soluble in alcohol.
Yes. So what is the reaction that is used? Very good. But what is the reaction that is used?
Vanderberg.
Very good. Excellent. Well done. Vandenberg reaction. That's all you need to know, which is excellent. It's soluble in alcohol, which is used as a Vandenberg reaction. So now what will you do? You know, having done that, having done all that, now what will you do? You've got this patient who's come in. What further investigations would you do?
Sir, I would like to perform ultrasonography.
Good. So we are going to give you just that. So that is an ultrasound. And the ultrasound is always very difficult. It's a very operator dependent. So I'm not going to bore you with this, but except to show you that that's the gallbladder. There is a stone. That you can appreciate that there's a stone. There's a posterior acoustic shadow out here. Okay. And there's a bit of hepatic infiltration. So gallbladder contains a large calculus. Walls are irregular with the infiltration of liver. Bile duct is 10.2 millimeter. What do you think about the size of the CBD?
So it should be around 4 mm.
Increase
Well,
Diameter.
I would put the
more
thing,
than
either
0.8.
some people say 6 to 7 millimeter is the normal. Okay. Anything more than that is dilated, anything low. So remember the value 6 to 7 millimeter. Okay. But after the age of 60, what happens to the bile duct?
Dilates.
1 millimeter increase for
Dilatation of
every
How
10
much
years.
does it dilate?
10%.
1 millimeter for 10 years.
Why, absolutely. Per decade, remember that was a good answer. 1 millimeter per decade for 10 years. Okay. What happens if you've had a cholecystectomy?
Then also CBD is dilated, sir.
Yes. Up to what would you consider as normal? Some authorities would put it at 10 millimeters if you've gone about 5 to 10 years post cholecystectomy. Okay. But this patient has the gallbladder, has a large calculus, a CBD of 10.2. So I want you to remember all this, because then what will you do? You've done this, now what will you do?
MRCP.
RCP.
Okay,
IHBA dilatation.
MRCP,
IHBA status.
okay, MRCP, you've done an MRCP. It shows dilated bile duct. Or you've got a dilated bile duct out here. Okay. You've got a dilated bile duct out here. Any other information that MRCP will fetch you? Why do you want an MRCP?
Intrahepatic biliary radicals.
See, if the bile duct is dilated, it is likely that the intrahepatic bile duct will also be dilated, isn't it? The patient
Sir,
is
any
jaundiced.
CBD stones. Sir.
Yeah, it could be a CBD stone. Of course, it could be, but would the patient have presented that like this?
More in favor of malignancy. Like that.
So more in favor of malignancy. You've got a hepatic infiltration. So
Infiltration will be
I
seen.
would suggest that having got out here, you want to find out whether it's operable or not, isn't it? Because the ultrasound hasn't shown. What I haven't said is there's no ascites. Sorry, I should have done that. So there's no ascites. So also out here, one of the stumbling blocks is people ask about the bilirubin metabolism. Now, who's going to tell me about the bilirubin metabolism? I've got all the organs out here. Bilirubin metabolism. How is it formed?
Excuse me, sir.
Yeah.
Sir, in the previous ultrasound, sir, could we know exactly where the dilated CBD is?
No, because I'll show you later. I picked this up because I needed to show the hepatic infiltration. I'll show you this patient. I have this patient CT scan, but I don't have an ultrasound scan. Okay.
Yes, thank you, sir.
So bilirubin metabolism. How is bilirubin formed?
So after the death of the RBCs in the spleen,
hemoglobin is broken down into heme plus globin,
Okay.
and that heme is converted into
Heme is carried out. Heme, the iron goes out. Iron is transferred by transferrin where? It is transferred into the bone marrow. Okay. So from you have iron breaking out from the hemoglobin. The heme is left. Now, how is heme transported? Heme has to be transported to the
Protein,
liver.
sir. Albumin.
It's transferred by globulin. So
globin.
Hemoglobin.
okay, so out here it is unconjugated bilirubin. It is taken up by the hepatocytes. Sometimes you have congenital problems out here which prevent bilirubin being taken up. So you have unconjugated hyperbilirubinemia.
So
So,
Gilbert syndrome
and Gilbert
and
says what?
Rotor syndrome also.
So you have Dubin-Johnson and Rotor syndrome. Okay. Right. Now you have conjugated bilirubin being formed out here. It's conjugated in the liver, the hepatocyte. Two conjugations take them. So diglucuronide. So it now gets excreted and you have a problem in excretion. So there you have something called a conjugated hyperbilirubinemia. Okay. So remember these two terms. So now we have bilirubin. And what does bilirubin do? It comes out into the intestine. Now tell me what happens next. Bilirubin travels through the intestine.
It is
Goes
converted
into the ileum where
enterohepatic circulation.
it goes back into the liver because intestinal bacteria break down the bilirubin into stercobilirubin and urobilinogen. Okay, and what happens to urobilinogen? 5% goes through into the kidneys, and so you have a yellowish colored urine. Okay, so you need to know this circuit completely well. Okay, please remember this, because once you do that, then you're going to get into the meatier stuff. And people are going to ask you what is the difference between the three types of jaundice: prehepatic, hepatic, post-hepatic. So type of bilirubin elevated, unconjugated bilirubin, and prehepatic. Hepatic, both conjugated and unconjugated. Post-hepatic, conjugated. Serum bilirubin Vandenberg test, indirect, prehepatic. Biphasic for hepatic, you have both direct and indirect going up. Post-hepatic is principally direct. Conjugated bilirubin in urine is absent. Urobilinogen is very high in prehepatic. Bile salt is significantly absent. In a post-hepatic, you have conjugated bilirubin, but you have bile salts also. Urobilinogen, you don't have in a post-hepatic because you don't have the enterohepatic circulation. So you don't have urobilin coming out here. In prehepatic, there's a huge amount of urobilinogen. So you would expect urobilinogen is colorless. You would expect it to be completely colorless, but it can be deep. You know why? Because on urine on standing, the urobilinogen converts into urobilin, which is yellow. Okay, so that is the controversy, which is why that has a different font. So remember that. Urobilinogen in early stage in a hepatic, you know what happens because the hepatocytes get inflamed. First stage is an unconjugated hyperbilirubinemia. And when there's edema, it presses on the bile canaliculi. So you have a blockage out there. So in the later stage, it becomes conjugated hyperbilirubinemia. So that is what is meant by a biphasic. So conjugated bilirubin early, urobilinogen present in early, not in late, and bile salts present in early stage. So urine color is dark because both are present. Stool is normal to dark, normal to pale in hepatic, depending on which phase the hepatic hepatitis is in. And a post-hepatic is pale. You have pruritus pronounced in a post-hepatic because it's a conjugated bilirubin getting into the subcutaneous tissue where you have free nerve endings that causes the irritation. So you have that's going to be asked. So remember that. So it's pronounced in a post-hepatic, absent or mild in a hepatic, and absent in a prehepatic stage. Okay. So take a screenshot of this if you will. So these are the must knows. when you know these must knows, then I'm going to ask you, what are the causes of jaundice in a cancer gallbladder? Right. I need people helping me out with this.
Sir, involvement of portal structures means infiltration of the
Okay.
porta will cause the obstruction in case of carcinoma.
So let's suppose you have a cancer out here. Very good. So it goes there. Okay. Involving out here. So let me just take this color, and I'm going to call it the CD is the common duct. So because you have the common hepatic duct and the common bile duct and the intrahepatic bile duct. So if that is there, is the common duct dilated? No, because it's blocked out here. Intrahepatic bile duct, it's already infiltrated out here. So no. Right. Now, second scenario. Now you have cancer at the neck. It's involving the junction of the common hepatic duct and the common bile duct. Right? So out here, what will you find? Common duct?
The common duct not dilated, IHBD will be dilated.
Very good. So IHPD will be dilated. Excellent. Now, somebody said, and that was excellent, because you had a stone, isn't it? You had a stone out here. You could have a stone which is trickling down out here. So if you had a stone out there, the presentation would have been completely separate. You would have had attacks of pain, colicky attacks of pain radiating through to the back, and you would have had sometimes jaundice with fever. What type of fever? Hectic rise of fever with chills and rigors. So these are terms you will have to use. So if you have a stone out there, so what will happen to the common bile duct? Dilated, as also the intrahepatic bile duct. So you see how important the history is, because now the next stage I'm going to ask you is, how else can a cancer gallbladder cause jaundice?
Extensive direct invasion of the liver.
We've already had that, the first stage. What else?
The enlarged lymph node at porta.
Very good. Good. Well done. That's wonderful. So enlarged lymph nodes follow what? You know that you have a spiral situation, and Dr. Sinha showed you that it goes into the retroperitoneal lymph node, and you also have a direct spread which goes down directly out here. So that is the two stages that the lymph node pathways follow. The other one is that you have also, you know, lymph nodes follow vessels. So you have another vessel out here. I'm drawing it in blue. So tell me, what vessel is this? And it receives another branch from here.
Portal vein.
Portal vein.
Portal vein. Very
Portal
good. So
vein.
you have portal vein. So you have lymph nodes traveling along the portal vein. As a result of it, now you have mesenteric lymph nodes. Okay, mesenteric. You have retropancreatic lymph nodes out here. You have mesenteric lymph nodes. Okay. Remember that I said that it follows vessels. So you have another vessel out here, which I'm going to draw in red. So what is that vessel?
Hepatic artery, sir.
Very good. So a hepatic artery. So now you have lymph nodes spreading out here. That can't cause jaundice, but when it reaches there, it does something. Now I want you to tell me what. That's a main thing which gives off 3 branches, but it also has, in addition, plexus of nerves.
Pain.
So pain, very
causing
good. Pain in the pain radiating, excruciating, not relieved pain radiating through to the back. Also, okay. The other thing you have, you remember that that's an artery that's going up. So you could actually have lymph nodes spreading up, hilar. Okay. Right. So And this is very important. Why is this important? Because without knowing that, you're not going to be able to get the CT scan. That is why I'm going through this. So again, you have the cholecysto-retropancreatic pathway. You have a straight posterior surface of the CBD, both drain into the retroportal node on the posterior surface. Okay. I think Dr. Sinha has already shown you these slides. Cholecystoceliac pathway, root running to the left, hepatoduodenal ligament to reach the celiac lymph nodes. You have the cholecystomesenteric pathway along the portal vein. We've discussed all that to the superior mesenteric route and the hilar route ascending towards the hepatic hilus. So that is present in 20% of cases. Right. So now we know that these are the ways that you can have jaundice. Okay. Right. So now that you know that, I'm going to show you the CT scan. So that was very important. See, you need to know the basics. So that is the first CT scan. This was the actual CT scan. That ultrasound, I've borrowed it off the net. So this was the actual CT scan. Don't answer, because I'm going to show you magnified portions of CT scans which are important. That was the other segment. Okay. Right. Now I'm going to ask you, what is number one?
Right kidney.
Kidneys both.
Right and left kidney, both. Okay. Number two?
Spleen, sir.
Spleen. Number three?
Rectus spinae.
No, erectus spinae is here. This is, you can see that erectus spinae is here. This is separate.
Trapezius.
Yes, very good. Excellent. Wonderful. Well done. So, number four?
Sir, 4 is transverse colon.
It is too wide to be a transverse colon, isn't it? Stomach. Very good. Okay, so what is number five?
Left lobe liver.
Liver, left lobe liver. Very good. That is a left lobe liver. Absolutely, I grant you that. Don't be so diffident. You're doing very well. So that is the left lobe of the liver. So if that's the left lobe of the liver, that looks like the falciform groove. Okay. What is this? What is number six?
Falciform ligament.
Very good. That is fat. So you remember, fat has a Hounsfield unit almost like gas. If you change the contrast a bit, you will see that it is not completely zero like gas. It can be, slightly more, 5, 6, 7, 8, 9, 10, up to 10. Okay. Right. So 5, 6 is falciform ligament. Very good. Excellent. Right. Now you tell me what is number 7.
It's the right lobe of liver.
Right lobe of liver. What is number 8? Aorta. Number 9.
IVC.
Very good. IVC. Number 10.
The gallbladder.
Very good. It is a gallbladder, and you can see that the gallbladder has a very irregular surface. So it has, let me choose a separate color. No, let me choose this color. You see that the gallbladder has a very irregular surface. It's infiltrated into the liver. What else is it infiltrating? What is number 11? Go ahead. No. Duodenum. It is wide. The oral dye is out there. So now do you remember that the patient recently has been having nausea and tendency for vomiting? Okay. Why do you think the patient, you see, the history is so very important. Without knowing the history, you cannot. So you see that is the gallbladder cancer infiltrating into the duodenum, causing a narrowing. Can you see that narrowing out there?
Yes.
Okay. See, I mean, that is how important history is. Okay. What is number 13?
Pancreas.
Pancreas. Absolutely right. Bang on. Very good. What is number 12?
Portal veins.
Very good. Well done. See, no wonder that faculty member was very impressed. That's the portal vein. Very good. So we know portal vein. That number 13 is the pancreas. What is number 14? This black structure out here.
Pancreatic duct.
No. It's a bile duct. That patient is jaundiced, isn't it? Okay. So now in a CT scan, you have one advantage. What advantage do you have? You can measure it, and you can measure it out here, and that measures approximately 10.12. Okay. Right. So you have a dilated bile duct right down to the end. Why do you think that dilatation is there?
It's a distal obstruction. Means,
It's staring at you in the face. I want you people to look at the. I want you people to look at this. See, what is this? This is the duodenum. Okay. This is the head of the pancreas. I'm taking you through a bit more difficult CT scans because you people are so good. That is why, you know, one of your faculty he's also an examiner, he was very impressed. So now that is the IVC. Okay, hang on, let me see. Let's look at the IVC. That is the IVC. Okay, right. Let's draw the pancreas in that color. Pancreas. Now tell me, what are these structures? What are these structures?
Retropancreatic lymph nodes.
They are the retropancreatic lymph nodes. I'm going to wipe out what I've drawn. Can you see them, retropancreatic lymph nodes now?
yes, sir.
Now do you understand why this patient has a distal bile duct obstruction? So if, now you tell me, if this patient, let's say, is free from the IVC, what sort of an operation would you need to have an R0 operation? What operation would you need to carry out?
Sir,
You would need to do a radical cholecystectomy with a pancreaticoduodenectomy. Absolutely right. Remember what Dr. Rudrajit Sinha taught you. Okay. Out here, I can see that the portal vein is fine. Okay. The portal vein is fine. It is not infiltrated, but there are nodes out here. If the nodes are operable, if the nodes can be separated from the IVC, the operation that you would need to do is a radical cholecystectomy combined with a pancreaticoduodenectomy. The results of that sort of surgery are not very good, unfortunately. You know, people, you know, don't have a very good response. So now that you've seen that, that is the lymph node that we were that we were concerned about, the cholecysto-retropancreatic pathway. Spirally, you need to remember your anatomy. Spirally anterior surface of CBD to right rear, straight posterior surface, and both into the retroperitoneal node. So now that you know that CT scan, that same patient, slightly pancreatic protocol, slightly lower, right? Now, tell me what you see. Everything else is the same, but tell me what you think about the bile duct out here.
Dilated.
sir,
See, you can see that is the bile duct. Hang on, let me just get my pen. That is the bile duct. Okay, that's getting infiltrated by this lymph node, isn't it? Can you see that lymph node?
yes,
Large
sir.
lymph nodes. Okay, but more significantly, notice something, that the portal vein has maintained its normal. Okay, but also there might be lymph nodes out here. And what is that lymph node called? It lies between two structures. That structure, and that is the aortocaval lymph node. Okay, so that is how you read a CT scan. Okay, well done. I think at your stage, I wouldn't have been able to do that. So that's very good. Well done. Okay, so now do you remember, now do you realize why clinics is so very important? You need to know that this patient has jaundice. You need to know that this patient has obstructive symptoms, and that you correlate your CT scan with your clinics. So you cannot cannot miss out on clinics. If you miss out on clinics, which is why you will realize that you are going to be, as surgeons, you have to be better than your radiologists as reading lymph nodes. We, at our unit, we always maintain that. Okay, because you know the clinical style. We very rarely tell the radiologist the complete thing. Okay, right. So the liver is the second most commonly involved organ by metastatic disease after lymph nodes, and the most common primary sites are eye, breast and lung, stomach, pancreas, and colon. Okay, right. In children, the most common liver metastases are from a neuroblastoma, a Wilms tumor, or a leukemia. And that's what an ultrasound looks like of metastases, and that's what a CT scan looks like. Right. Now I'm going to show you a series of two sets, this and the other. And because this is metastases in a liver, you can see I think somebody needs to mute. Hello, somebody needs to mute their connections, please. Okay, so if I now show you, that's one, that's the other. Appropriate side, you'd find that it is hypodense, but it has a peripheral rim enhancement. Okay, multiple lymph nodes. Now I'm going to show you the next plate, and you're going to tell me, because you're doing well, you're going to tell me what do you think this complete feature is. Now, next. What do you think? She's a 78-year-old lady. Go on, chaps. I expect you to.
Breast, carcinoma breast.
Right, very good. Carcinoma right breast. So you've got a carcinoma right breast out here. Okay, well done. Good. So you've got a carcinoma right breast. From there, you've got a metastases to multiple sites of the liver. Very good. Excellent. Right. Now we're going to, having done all this, you need to get the basics right. So we're going to go a bit more into a bit more theory. Right. So in an MRI, what are the changes? T1 is a moderately hypo-intense lesion. T2 is mildly to moderately hyper-intense. But the moment you use it with contrast and you use it in the T1 phase, either you use gadolinium, enhancement may be lesional or perilesional. Small lesions less than 1.5 centimeters tend to uniformly enhance, but larger lesions more than 1.5 centimeters tend to show transient rim enhancement, that is with washout. Helpful feature in distinguishing a metastases from a liver hemangioma, and we know what a hemangioma does. It's creeping enhancement. Perilesional enhancement is most commonly seen in colorectal and pancreatic adenocarcinoma metastases. But if you were using Eovist, you know what gadolinium goes for the hepatocytes. Eovist goes for the Kupffer cells. Very good. So Eovist is often useful for detection and confirmation of metastatic disease on the delayed phase. Metastatic lesions do not retain any Eovist and essentially appears as holes in the liver. Okay. The other interesting thing is when you're doing an MRI is a fluid level, if you see in a lesion, are considered a specific finding for neuroendocrine tumor metastases. Okay, just remember that. So that is a CT scan, and I've got this from Medscape. You see rim enhancement out here. That's a T1 weighted image. Okay, T2 weighted image filling up lesions, particularly if you've used gadolinium. So hepatocytes start staining. You can see that it forms an enhancement, right? Okay, the liver provides a fertile soil in which metastases may become established, not only because of its rich dual blood supply, but also because of humoral factors that promote cell growth. The blood supply of the liver is exceeded only by that of the lung in terms of blood flow per minute. Fenestrations in the sinusoidal endothelium allowed a foothold into the space of these for tumor emboli arriving via the bloodstream. So most liver metastases, I'm now going to go into a bit of theory, so you need to know that, but you will need to know that after knowing your basics. So most liver metastases are multiple. In 77% of patients with liver metastases, both lobes are involved. In only 10% of cases is a metastases solitary. Multiple tumors often vary in size. This fact suggests that tumor seeding occurs in episodes. Tumor cells get shed at different phases. So because it occurs in episodes, you have different sizes of metastases. In few tumor types such as colonic carcinoma, carcinoid, hepatocellular carcinoma, metastasis is confined to the liver. But most tumors that metastasize to the liver, such as breast and lung cancers, would have spread to the other sites at the same time. And this is the malignant cascade. The primary neoplasm shows progressive growth, vascularization, invasion, detachment, embolization, survives in circulation for a bit, then gets arrested in the liver, extravasates into the liver tissue, evasion of host defenses, progressive growth, and revascularization. So you need to know this is the malignant cascade. And what I'm going to tell you next is very, very specific trials that have been carried out. So factors in the mode of liver invasion: the tendency to retain a round shape, the adhesiveness of different types of tumor cells and their adhesiveness to hepatocytes, the inability of some tumor cells to survive and proliferate in the bloodstream for long periods, the pressure on the surrounding tissues and the formation of tumor cells and hepatocyte junction, tumor cell locomotion, host tissue destruction by enzymes elaborated by tumor cells. Looks very confusing, but I'm going to show you little diagrams. This was a study which was done across the Pacific. It was a combination of trial carried out in between New Zealand and Japan. And that is a wonderful study carried out on cancer cells in dogs. And I'm going to show you that. The pathologic anatomic characteristic of metastases: the pathologic anatomy of metastases resembles that of the primary tumor. Most metastases are hypovascular, which is why you only see a peripheral rim enhancement. But some primary tumors are characteristically hypervascular. Metastatic tumors of the liver may either be expansive or infiltrative. So the hypervascular metastases could come from the breast. Breast actually has both. You have a hypovascular or a hypervascular metastases. Melanomas are hypervascular. Renal cell carcinoma are intensely hypervascular. Pancreatic islet cell cancers are hypervascular. Endocrine tumors are hypervascular, as are sarcomas, leiomyosarcomas, and choriocarcinomas. So remember that if you might be asked which are the hypervascular secondaries: breast, melanoma, renal cell, pancreatic islet cell, endocrine tumors, sarcomas, and choriocarcinomas. Hypovascular is breast, lung, pancreatic cancer, and colon cancer. If you have a neuroendocrine tumor, that falls into the hypervascular as well. So basically, it sheds from the gut, comes into the blood. From the blood, they travel into the hepatocytes. And from the hepatocytes, sometimes you go beyond into the sinusoids. And you know that the liver is nowadays microscopically divided into 3 zones. So do you know which zones? Zone 1, Zone 2, and Zone 3.
So away from the central vein.
Yeah, so the central vein is which zone? Let's suppose that is the central vein. So which is that zone?
Zone 3.
Whoops. What
Zone
happened?
3.
Zone 3, very good. Now what's happened to my sharing?
Zone 3.
Can you see my sharing? You can't see my sharing, no?
No, sir.
No, sir. Yes, sir.
Oh, hang on, I managed to, that was quite impressive. I never managed to do that before. Hang on. Let me find out where we've gone. Yep. So zone 3 is around the sinusoid and zone 1 is around the portal triad. Okay? Right. and in between is zone 2. Remember that. So now this was the trial that was carried out between Brett, somebody called Brett, and somebody called Nagatsuma. And this was published in 2007, and I was chasing it up. And this was a wonderful experiment. And what they said, this was colon cancer in dogs. 1 to 8 hours when colon cancer cells were encountered in the liver sinusoids, 90% of the tumor cells are eliminated by a synergistic action between the Kupffer cells and the natural killer cells. The Kupffer cells digest that, they absorb the cancer cells and they destroy it. The natural killer cells use IFN gamma and nitrous oxide, and they induce apoptosis. So 90% of tumor cells are eliminated. Okay, so that's 1 to 8 hours. 4 to 8 hours. Now what happens is tumor cells have this transcellular protein called FAS, and you have a FAS ligand. So you can well imagine that if you have something that hits that FAS ligand, that transmembrane protein gets destroyed and the cells are destroyed. So about 5%, remember that 10% was left over, 5% of colorectal cells population express functional FAS under the influence of IFN gamma and nitrous oxide released in the sinusoids by natural killer cells and by the hepatic endothelial cells respectively. In this situation, the IFN gamma activated pathway supports the immune system by inducing apoptosis in the cancer cells. Unfortunately, what happens now is that some cancer cells have the FAS ligand and some hepatic endothelial cells have the FAS. So now that works in a reverse direction. So in working in a reverse direction, these cells see that they search for the hepatic endothelial cells which have the FAS. And having found one, they attach out there. The moment these cells are under stretch, so the moment that cells get apoptosis and destroyed, it stretches, allowing the cancer cells in. So once the cancer cell goes in, you can see that now they can work their way through. And because it has a FAS ligand, hepatocytes also have that FAS ligand. So they actually start invading the liver completely. So that is the way. So 95% of tumor cells actually get eliminated. It's only the 5% that creates havoc in the body. So just remember that. Okay. Right. Now I'm going to talk of the colorectal metastases. I'm going to give you 2 scenarios. This was a 60-year-old man who initially came to me with synchronous cancers of the sigmoid and the transverse colon. And guess what he underwent? Because he had a synchronous cancer, he had a complete workup. CA was normal, his CT scan was normal. He underwent a total colectomy and an ileorectal anastomosis. He had 6 cycles of adjuvant therapy with FOLFOX4. He was on follow-up, and at the end of 4 years, guess what? He presented with gallstones. And in addition to this, he presented with this CT scan. So what do you think is present on that CT scan?
Secondary.
Not secondaries, one particular secondary where in the left lobe of the liver. Okay, can you say that?
Yes,
right. So yeah, so what we did initially was to do this operation. We did a cholecystectomy and we did a proper left hepatectomy. So he goes home. He's actually this gentleman is from Bangladesh. He comes back later, 2 years later, he comes back with this. Now what do you think he has?
It's a lung metastasis.
Left lung metastasis, right? A solitary metastasis, a cannonball metastasis in the left lung. Right. Now, I'm not a cardiovascular surgeon, so one of my cardiovascular colleagues went ahead and did a segmental resection of that. Okay. He comes back 4 years later, doing very well. And then subsequently, so this is almost 10 years after his surgery, and he drops out of follow-up. Okay. I after 10 years he didn't come back. 4 years after this, so 4 + 2 6 + 4 is 10 years. He kept on coming, following me up. He outlived his wife, and then he's just dropped out of follow-up. So I don't know what went wrong after that, but hopefully he's still fine. So in a study from 99 centers, liver resection was associated with 20% 5-year survival, as opposed to 0 with any other therapy, ablation, radiofrequency, alcohol, whatever. In a single sector trial involving 1,001 patients, the result was 40% 5-year survival, and that was principally MSK-CCC, human Fong, 40% 5-year survival with median survival of longer than 40 months. Human Fong from MSK-CCC. He had a great fight going with famous Bloomgard. They couldn't see eye to eye, though they were in the same department, but there we are. Right. Now we have this young executive, another patient, 46 years of age, and I showed this previously when I was discussing the appendix. This chap actually presented with recurrent attacks of appendicitis, and then subsequently, but infrequently, bowel obstruction. And this CT scan revealed this. This was a coronal section. So what do you think his CT scan shows?
Sir, carcinoma ascending right flexure,
near the hepatic flexure. Okay.
Flexure.
Okay, near the hepatic flexure. Very good. Excellent. Right. But unfortunately, it also showed that. What do you think that shows? Secondary hepatic metastases. Now, theoretically, both patients had stage 4 colon cancer. Is the management the same? Now do you understand the predicament, that the controversy? We call both a stage 4 colon cancer. The first patient, the elderly patient who came in 4 years later, he had a synchronous, he had a total colectomy for a synchronous cancer. And this chap comes in with a synchronous metastases. So is the management going to be same? They are both stage 4 colon cancer. So you see, that is the problem. The problem is all patients who have liver metastases are staged as stage 4. But there's some considerable diversion between the group. Therefore, to prevent a blanket homogenization of the group on attempt to define prognostic variables is needed. And there were 3 major trials. One was Human Fong, of course. Nordlinger was the other, and Hughes. So see what they said. If you compare it, primary stage influenced your decision. Synchronous, if you had a synchronous metastases, that was bad news. The size of the metastases was very important. If it was a large size, that was bad news. Number of metastases, particularly if it was, we'll come back to the biloba later. It was important, the number of metastases. As also was, if you couldn't achieve a surgical margin when you were resecting the metastases, that was bad news. And the CEA more than 200 was also a bad news. 2 of the studies, Hughes and Fong, also said that if you had a bilobar metastases, that was also bad news. Whereas Nordlinger said, no, bilobar wasn't important. Therefore, as a result of this fabulous study, this was very good that people thought of this and did this study. What are the factors that determine prognosis? Synchronous presentation, a CA level of more than 200 nanograms per ml, positive lymph nodes, serosal invasion, shorter interval to metachronous lesions, number of lesions on CT scan pre-op, resection margins less than 1 centimeter, size of metastasis more than 5 centimeters, and a bilobar disease. These are adverse prognostic factors. They are not a contraindication for surgery. So Mala in Norway, he actually did a scoring system, the prognostic scoring system for hepatic colorectal metastases. Node positive primary tumor is 1. Disease-free interval less than 12 months between colonic resection and evidence of metastases, he scored 1. Large size of the lesion, if it was more than 5 centimeters, he scored 1. More than 1 tumor was 1, and CA more than 200 was 1. And so if you score 1 for each, 1 to 2, if the score was 1 to 2, you went in for resection. If it was 3 to 4, you went for aggressive adjuvant therapy plus minus resection. If it was score 5, poor prognosis, resection plus adjuvant only in a clinical trial setting. Okay, otherwise you would try and avoid. That was way back in 2002, almost 18 years ago. The classic contraindication as it now exists, you know, and this was one of the conferences that got everybody together. Biloba disease was a classic contraindication. More than 4 lesions was a contraindication. Large tumors more than 5 centimeters was a contraindication. And an extrahepatic disease was a contraindication. So this was the consensus at the San Francisco conference. So it was a conference, consensus conference. So what is too much for surgery when an R0 resection cannot be expected? When do you do a surgery for CLM? What is the advantage? Survival 5-year rate for complete resection is 40%. That is huge. And that is why people stretch themselves and try and resect these tumors. Operative mortality, 2-month operative mortality should be less than 5%. Post-op morbidity is sometimes quite high. It's about 28%. What is unresectability? What qualifies as unresectability for the liver? More than 70% of liver volume can be if it's affected. More than 6 segments involved. Invasion of both branches or 3 hepatic veins. And possible scope, you know, you consider a possible scope of rescue surgery after neoadjuvant therapy. So neoadjuvant therapy, what are the neoadjuvant therapy that we use? You use 4 to 6 cycles of the new effective chemotherapeutic combination such as Folfox or Folferi, oxaliplatin or irinotecan, that's the difference, with either bevacizumab or cetuximab. But excessive use of chemotherapy can cause liver steatohepatitis. If you were using oxaliplatin, you sometimes have steatohepatitis and vascular complications with using, I'm sorry, it's the other way around. If you're using irinotecan, you had steatohepatitis and vascular complications were more with oxaliplatin. You remember that we had focal nodular hyperplasia associated with the use of oxaliplatin, and focal nodular hyperplasia has something to do with vascular sinusoidal obstruction. Right. So this was another brilliant study carried out by an Indian scientist who actually started working at the Massachusetts General Hospital. His name was Rakesh Jain. And he said that in a normal tumor, it's a balance between anti-growth factors and growth factors, that large vessels branching to form normal. That's the normal permeability. What happens in abnormal, what happens in a tumor is that you have pro-angiogenic factors, vascular epithelial growth factor, overgrowth. So you have a haphazard oversight and dysfunction in microvessels. Now, when you, it was one of his studies basically to use the biologics. So if you used a biologic, you normalize growth, you inhibit pro-growth signals from VGF's prunes, and VGF prunes immature vessels, restoring a normal vascularity. But if you keep on using it too much of pruning so that additional therapies cannot work, or you have a compensation. Other growth factors surge to compensate for your vascular endothelial growth factor inhibitors. So you had abnormal vessels that grew. So this is why the timing of surgery, complete radiological response should not be achieved, as planning for surgery may be difficult. Complete response is almost always associated with recurrence. That was the reason that you do not wait for complete resolution. CT scan at the time of presentation to be taken into account, and timing of the therapeutic window provided the response to chemotherapy was sound. So 6 to 8 weeks after discontinuation of bevacizumab to avoid its anti-angiogenic effect, the Rakesh Jain effect that you saw. Okay. So role of surgery, if the tumor progresses despite neoadjuvant therapy, it is vital to control tumor growth prior to surgery. if you have to offer a chance of prolonged remission. If there's growth despite neoadjuvant, please do not offer surgery. Recurrence rate in patients who have had so-called curative hepatic resections, 60 to 80% who have undergone hepatic resection will develop local, regional, or distant recurrence. 85% of recurrences will occur by 30 months. 30% will be confined to the liver. Repeat resections, are they safe? If within the limits of normal liver volume and function, go ahead, provided R0 resection can be achieved within the limits. Not worthwhile if you're leaving a positive margin left behind. And you may try RFA, radiofrequency ablation, or portal vein embolization, ligation, or alcohol injection may be considered. Now, this is a controversial subject. Combined or straight procedure, there are two controversial subjects. Do you do a combined straight procedure? It's controversial. Overall, the survival is the same, but combined procedures have less complication rates. Personally, I have personally done liver with left lobes on 3 or 4 occasions, and I've been very fortunate with that. But you know, you can argue that sometimes if you add a colectomy with a hepatectomy, the chances of complications are more. So you can argue against that. So if you're us, the name to remember is Figueras. He's, you know, big dad in liver and colon surgery. Remember this term, Figueras. But remember also that the San Francisco conference said it's controversial. So you might say it is controversial. You can do probably the colon first, treat the patient with chemotherapy, then go in for hepatectomy later. It's perfectly acceptable. Now, this is the most controversial thing, but you must remember that some examiners actually ask this. State surgery, which procedure first? And all this was because of this man, Mentha, who had this article in the British Journal of Surgery in 2006. Classically, you handle the primary and then the colorectal metastases. But the issue is, in many cases, the colorectal metastases progress very rapidly despite treatment. And the lesion that kills the patient is supposedly the metastases, not so much the primary. So Mentha designed a protocol where he had a very first, a high impact chemotherapy was given, went in for a resection of the colorectal metastases, and third, the removal of the primary. It is extremely controversial, but remember that this study, through the cat among the pigeons, as it were, a lot of discussions were carried out. And but I think you need to know, if you're asked, keep it in reserve. You can, if your examiner asks that, you can come up with this. But you have to say that if you have an intestinal obstruction brewing, there's no way you should handle the liver first. Okay, so remember that. Now, we're coming into neuroendocrine metastases. Hepatic neuroendocrine metastases, you opt for a CT MRI or a PET CT, or even better, a somatostatin scintigraphy. Resectable or resectable primary NEC and unresectable primary NEC. So if you have a resectable primary NEC and you find that above 90% of hepatic metastases resectable, so you go in for a resection of the primary and a resection of the liver. This is accepted in a neuroendocrine tumor. It is accepted. If you have a recurrence, if you have a limited hepatic metastases, you can go in for an ablation or a resection. If you have a diffuse hepatic metastases, you go in for an embolization or a somatostatin analog therapy or a systemic chemotherapy. One of the first distal pancreatectomies that we did was a neuroendocrine tumor, and this was one of our matron's father, and he had a single metastasis in the left lobe. So we went ahead and did a laparoscopic operation. We did a laparoscopic distal pancreatectomy and splenectomy, and we removed a wedge resection of the metastasis because it was right in front of us. But unfortunately, he came in with this situation. He came in later with a diffuse hepatic metastases, and we treated him with embolization and systemic chemotherapy. He's still around because the problem with the neuroendocrine metastases is that it is hugely symptomatic but spreads slowly. So 90% less, if you have less than 90% of hepatic metastases resectable, then you might, this is the only time if you do not have any extrahepatic disease that you may consider a liver transplantation. So if you have an unresectable primary neuroendocrine tumor, palliative operations as indicated. If you have hepatic metastases, limited hepatic metastases, you can go in for a percutaneous or a laparoscopic radiofrequency ablation, or use an embolization or a cryoablation. If you have diffuse hepatic metastases and an unresectable primary, there's no point going in for a transplantation, embolization, or chemoembolization, somatostatin analog therapy, and or a systemic chemotherapy. Okay, so non-carcinoid metastases, poor results as liver, and I told you the breast and lung, they spread elsewhere. So poor results of liver is not often the first port of call. Of some value if liver recurrence has a long disease-free interval, which means you have a better tumor biology. But poor results if primary has already shown vascular and perineural invasion. So this was the ultimate thing. So colorectal metastases, go in for resection. Neuroendocrine cancer, go in for resection. Anything else, be very, 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 very cautious. All right, chaps, any questions?